Hello and welcome back to Bedside Murmurs, a podcast where we chat with doctors about their careers, pathways in medicine, clinical tips, and much more. If you have any questions or have any ideas of guests you want to see on the show, please shoot us an email at podcast@medsoc.org.au. That's podcast@medsoc.org.au. I'm Sean.
And I'm Emily, and we will be your hosts. Today, we have the pleasure of speaking with Professor McKenzie, who is a senior anatomical pathologist at Royal Prince Alfred Hospital. She has a wealth of experience in gastrointestinal, liver transplantation, and skin pathology. Professor McKenzie is the current chair of the Academic Committee of the Royal College of Pathologists Australasia and the president-elect of the International Academy of Pathology, Australian Division. She has vast experiences in teaching and mentoring medical students and pathology trainees, and she has extensive research experience, including work with the World Health Organization and publications in the New England Journal of Medicine. Alongside this, she has a keen interest in engaging medical students in pathology and in addressing gender disparities in pathology. So welcome, Professor McKenzie, to Bedside Murmurs. It's a pleasure to have you with us today.
Thank you very much for having me. I'm very excited to be here.
So could you tell us about your time at medical school?
So I did a 6-year course like you guys back in the day at Sydney University in the 90s, and I loved it. I think and I don't know if it's something you're finding, but being with that group of like-minded peers for 6 years with a stimulating academic environment was fantastic, and I remember it fondly as one of the best periods of my life.
When you were at medical school, did you have any experiences with pathology at all?
So I guess it's interesting because, there's been this move to postgraduate medical curriculum in many medical schools, and there's pros and cons of the different programs. I think an advantage of that 6-year undergraduate program was we did have a really solid grounding in anatomy, histology, and pathology. But possibly the drawback of the teaching is that it was taught more as a sort of clinical science or a basic science rather than as a career. So I managed to go through 6 years of medical school without really realising pathology was actually a career you could do. I found it very interesting, looking at down the microscope and making the diagnoses, but didn't actually really think of doing it until I was in my resident year, which I think you'd call PGY 2 year now.
Yeah, that's actually a really interesting idea. Could I ask, when during your medicine course did you start going into the clinical years of medicine?
So we had the first 2 years we didn't do any clinical medicine.
Oh,
so it wasn't until, and obviously some of this did need revamping.
Yeah.
So we did things like physics pracs where, you were rolling balls down.
Oh wow. This is so high school coded.
Exactly,
Yes.
exactly. And there are obviously good arguments for cutting that out of it.
Medicine course.
Med school curriculum. So it wasn't until third year we started going one day a week to the hospital.
Oh, so
I believe you do it much earlier now, which is obviously better.
Yes.
The earlier you're exposed. So our first years were all, more like a science degree, I guess.
And then, out of interest, does that mean you transitioned more into clinical teaching in the later years, and then it just became more
Correct.
full-time?
So 4th, 5th, 6th year were pretty much all ward-based. 4th year, I can't remember now. I think we were 3 or 4 days in the hospital. Then 5th year we did rotations through paediatrics, ONG, psychiatry, and GP term, and then 6th year you're back doing medicine and surgery before you finished.
But as you mentioned, that's really interesting because you went through all of these terms, and pathology obviously was really, really intertwined within everything you learned, but maybe it wasn't clear within the medical school that you could do it as a full career. Correct,
because you didn't actually do a placement in pathology as such. So we learnt it, main teaching was in 3rd year.
Okay.
Then in 4th, 5th, 6th year, we didn't really have a lot to do with it directly. I think your course is a bit different.
Yes.
But at that time at UCID, we didn't have much to do with pathology after that.
That's really interesting. So you're an anatomical pathologist.
Correct, yeah.
Could you tell us a little bit about what that specifically is, and what does a pathologist actually do, and how do you become a pathologist?
Yep, so
anatomical one.
Pathology, as you know, there's lots of different types. So you've got your haematologists, microbiologists, genetic pathologists, forensic pathologists, and some others I've probably forgotten, and anatomic pathologists. So we look at all the tissue. So anything that's biopsied or removed from a patient comes to the laboratory, is processed, and we look at it under the microscope. So one of the main jobs of our trainees is to handle the specimens that come in. So it's called cut-up or macroscopic dissection. And it's kind of like surgery, except it doesn't matter if you...
Low-stakes surgery.
That's right. Well, no, it's very important, obviously, that you handle the specimens correctly and take the margins and what have you, but there isn't that pressure of the patient bleeding to death.
Yeah, actively in front of you.
Correct. Correct. So once the registrar's handled the case, then we get it get processed and made into glass slides, and then we make the diagnoses. And sorry, you had a two-part question there, and I think I've forgotten.
Yeah, the second part was essentially, how do you become a pathologist?
So like all or most medical training schemes, you do your 2 years after finishing university, and then most people apply during their PGY 1 year. And it's a 5-year training scheme. The first exam you do is called the BPS, or Basic Pathological Sciences, and quite a lot of people do that as a medical student. You don't have to, but it's cheaper.
Yes.
It's not an expectation, but it's obviously useful to get onto the training scheme. Then in third year, you do your part 1. Fourth year, you do cytology, small biopsy exam. And then final year, you do your part 2. So it is quite an exam-heavy profession. Then, technically you're qualified and you can go out there and get a job. So when people start, we don't expect them to know a lot of pathology. Most people have done, or there's a limited number of resident terms available in New South Wales. So, we're aware that only some people have access to them. So most people pretty much start from scratch. So there is a huge knowledge acquisition from first to third year. But, by the time people do their part 1, they have pretty good grip on pathology. When you think about it, we cover every tissue in the body and every disease, benign, inflammatory, malignant, involving every organ. So we cross all disciplines, really. It's and we see the most interesting cases from all of them. So it's a very interesting field.
And why did you decide to become a pathologist? What was it about pathology that drew you to the specialty?
I mean, I don't think there was a single light bulb, light bulb moment. But I think during med school, and again, I'm curious to know if it's changed now, but really I thought there were 3 options: medicine, surgery, or GP. And I quickly ruled out surgery because, the workplace culture and, as a woman too, it's not exactly, it's trying to improve, but, not super welcoming. Didn't really want to be a GP, so I was fixed on physicians training for most of medical school, and particularly neurology. I really liked that sort of problem-solving puzzle. And I even applied for the physicians team, but physicians training, and got on the scheme. But sometime during my resident year, I just realised I didn't want to be doing ward work and long hours and weekends and on-call for the rest of my career. And I guess some people thrive on the wards and like that high drama, but
a lot going on. It's quite busy. It's enough to keep you entertained.
Correct. Or something like A&E where stuff's coming in all the time, but that's not me. So I like the calm environment of a pathology laboratory, and I started asking around and finding out more, and then decided to apply to pathology at the same time. And just realised it was better choice for me. I always found it interesting. I like the relative calm and control of the environment, and it's always interesting, challenging, and lots of opportunities within the profession as well.
Yeah, I agree. Like, I think for people that haven't done ward rounds are a specific like kind of environment, and you need to really be in a ward round to understand what kind of like flavor it is. And a lot of internal medicine specialties that ward round, each of the ward rounds are different, and that's why people obviously encourage the rounding of each of the specialties so you can understand what kind of environment you work best in. And it seems as though like when you went into pathologist lab, that was the environment that kind of like spoke to you the most.
Yeah. So I did a oncology term in my resident year, and we had a lot of contact with pathology because, of course, it's so integral to making the cancer diagnoses. But I remember being asked to follow up some cases with a pathologist and going to their office, and they'd put the slides on, invite me to have a look, and I realised I was much more interested in
watching the slides.
that aspect, and just seeing how critical it was. You know, you're waiting for the pathologist to make that decision so that all the subsequent decisions could be made about how the patient was managed, what treatment they would get, what their prognosis was. You know, you really do give the answers to so many of those questions.
I'm reflecting that, especially when I go on ward rounds, it's really interesting that you take a specimen and you go like, oh, just give it to the pathologist. And especially it's because when you round, you don't know the answer to a problem. And then you take the specimen and then you just expect the answer to come back in a few days.
Yeah.
And that kind of process is so like far removed from the actual hospital setting that it's difficult to have that experience unless you go, as you did, to a pathologist's office and see that kind of action happening.
It's all the behind the work scenes, behind the scenes, I guess.
Yeah.
Cut that. Like behind the scenes work that we don't normally see. That actually is really important in medicine. I mean, without pathology, so many clinical decisions you just couldn't make.
Exactly. And if you think if a patient comes into A&E, you know, blood tests, you know, form part of everything, and I guess radiology is the other diagnostic specialty that's maybe a bit less visible, but they're all equally important in getting the best outcome for our patients.
And what does your day-to-day job look like as an anatomical pathologist?
So I guess our bread and butter work is reporting.
Okay.
So we get glass slides and generate a report using. We have access to PowerChart. I don't know if you. So you know, it's really important to also integrate all the clinical. You know, sometimes people think we operate in a bit of a silo, but it's really all that clinical information's really important to put together to make a meaningful diagnosis for the patient. Then multidisciplinary meetings. So those cases are brought to. So to use colon cancer as an example, then you have the oncologist there. The surgeon, the radiation oncologist, and the pathologist, and depending on the type of tumour and the stage, decisions are made about subsequent management. We do frozen sections or intraoperative diagnosis. So I guess it's a higher stress aspect of the job where the patient's under anaesthetic and you have to give you'll be like right there, like you're just watching. Yeah, so you're not in theatre per se, but they give you the tissue, and rather
as the surgery's happening.
Correct. So normal specimens we put in formalin for 24 hours, and then they're put in wax and cut, and that's the glass slides that you'd have seen.
Yes.
Seen in teaching, whatever. In frozen sections, they freeze the tissue, and you diet and look at it straight away for an instant answer. The drawback is that quality is not as good because freezing doesn't.
I can imagine,
it doesn't preserve the tissue as well as the paraffin embedding, but it does give an answer on the spot. So it might be if they're not sure if something's benign or malignant, or if they're worried that a margin's involved and they need to know whether they can stop there or do more extensive surgery, or sometimes in the neuropathology they're not sure if it's a lymphoma or a cancer, which has quite different consequences, for the patient and the way the tissue's handled. That's probably one of the more stressful aspects of the job. But having said that, you can still show a buddy. You can do a job, buddy.
What they don't tell you about
Yeah,
teamwork.
that's right. Yeah, that's right.
Yeah.
That's right. You ring the report
Yeah,
through
so
with
it's
total confidence, but you
Yeah,
should. Yeah.
Check this for me.
Yeah,
Yeah.
yeah. But no, you can.
Of course, yeah.
You know, especially when you're more junior. You know, show a colleague, which is great. And then teaching. So trainees, I do a specific tutorial and some, you know, formal lectures and the like. But a lot of it's just day-to-day teaching on the run, if you like, with individual cases. And they do a provisional report before we sign it out, which we look at with them and whatnot as well. And then also medical students as well when I have the opportunity or when I'm asked to do teaching for them as well. So it's quite busy, I guess. And then I have roles through the College of Pathologists and the International Academy of Pathology as well as some research projects going. So that the clinical work always takes... sorry, didn't mean to knock the microphone there. Always takes main stage or you know, priority. Yeah. So some of the other stuff has to be sandwiched in between. I think whatever job you do in medicine,
It'll be very similar.
There's budgets. There's a constant tug of war between
money.
you know, service delivery and things like research, which are really important. You know, really important as well. So really bored.
Yeah. There's an interesting thing that you brought up along in the middle when you said that you can show it to a buddy. And I thought that was really interesting because especially in medical school, it can feel as though like it's more important to act like you know what is going on as opposed to be very certain about it. And in a clinical scenario, especially when you need to know the answer and you need to know that your decision is correct because it's impacting lives, it's so much more like the stakes are so high that you should always, like, if you can, ask someone to have a second opinion and
absolutely
essentially be certain of something before you send the report out. And I think that's a really interesting aspect of medicine that could be emphasized.
And it's nice to hear consultants and people who are higher up encouraging teamwork. Sometimes it can feel like a solo race, but that's really lovely.
And I've always found in pathology a very healthy culture in that respect, that you're not expected to all know everything. We talk about having aunts and uncles in the departments. You know, awesome. I know. Sort of pathologists, and I've realised now I think I'm an auntie. But you know, people who have 10, 20, 30 years experience, and I suppose in some fields, like, I don't know, finance, you might be seen as less relevant or whatever. But you know, in medicine, that
experience
depth
speaks.
and breadth of experience is so valuable. And we certainly try to take care of our junior consultants as well as they, you know, start practicing.
You have many different interests in pathology, like you touched on a little bit earlier. One of those interests is liver pathology. Do you think you could tell us a little bit about what you've been working on in that field?
Sure. So Prince Alfred has the liver transplant unit for New South Wales.
Okay.
So because it's a very specialised service, it's a state-based service, because it wouldn't be practical or give the best care if they were done in multiple centres. So there's a few things like that. So we get all the transplants for New South Wales. So with that, we also get a lot of pre-transplant biopsies.
Okay.
So to establish the diagnosis, and then biopsies after transplants, looking for rejection. So being involved in, day-to-day work with that, but also with an international group called BAMF Working Group, who sort of sets the parameters for the staging of rejection.
Okay.
Rejections are sort of, it's a bit of a Goldilocks dance, because you don't want to over-immunosuppress people, because then they start getting second malignancies or infections, and you don't want to under-immunosuppress them.
Because otherwise...
they lose their organ. So biopsies play an important role in seeing whether the organ's being rejected or not, because there's lots of different reasons they can get elevated liver function tests, but there's a limit to what can be done on the blood. So that's where we come in. Another aspect I'm very interested in is drug-induced liver disease. And so every year we get a few transplants for herbal and supplement-induced injuries.
Oh, wow.
So I find that quite interesting because it's quite an unregulated area, the herbal supplements. So we had someone who had a transplant from taking green tea extract. And
aggressively or like just normally?
Just normally.
Oh, wow.
Normally. And there's a weight loss supplement called Garcinia cambogia, which comes from some plant. And, these are, people buy them on the internet.
Yeah.
And the other paper just published, which was a study from around Australia, was on gym supplements. So some of the bodybuilding supplements and steroids and steroid analogues can also cause quite marked liver damage. So I just published a series of those as well.
Oh, wow.
So it's very interesting. I think in like luminal gut pathology, so endoscopies, certainly in adults, it's a bit of a screening test. If someone presents with PR bleeding, they have to have it would be negligent not to scope them.
Yeah.
But a lot of them are normal, whereas they only really biopsy the liver
when something's drastically, when they are clearly yellow.
Yeah. Maybe not quite that long. Maybe not quite that long. But when they're very suspicious that something's,
it's
going
not a standardized
on.
test.
Correct. And it's quite invasive.
Yeah.
And it has risks of bleeding and whatnot. So they don't do it lightly.
It feels a lot more scary to have like a pole stabbed into you than like just a scope passing through.
Yeah, absolutely. I was really surprised I was speaking to someone from the UK and they did liver biopsies themselves on the ward. Like we only ever do them under imaging, but their registrars would, tap.
Wow.
Oh, like just like percuss and go for it.
Yeah.
Oh.
Wow.
Yeah.
I mean, that's
fascinating.
one way to do it.
That's confident.
But most centres now do it under imaging.
Which makes them much safer.
Yeah, but we get really interesting cases. In the meeting this week, there was a patient who had a history of heavy alcohol intake and had also had Augmentin for a respiratory tract infection, went yellow.
Oh.
So they weren't sure if it was the alcohol or the Augmentin. But when we looked under the microscope, they didn't have many features of alcoholic liver disease. I don't know if you know what they are.
Oh, this is a terrible test.
So
fatty liver cells?
there you go. Yeah, that's right.
Yeah.
So fat, neutrophils, Mallory's hyaline. So didn't see that, but saw in fact they'd lost all their bile ducts.
All of them?
Yeah, so there's a rare it's called vanishing bile duct syndrome. So very rarely
That's self-explanatory.
as a drug reaction.
My goodness.
Patients get severe damage to their bile ducts. So they're being listed for their bilirubin's 900 and something. So they're being listed for transplant.
Oh, would you just transplant like the entire bile duct or like
The whole liver.
The whole.
Oh, wow.
Yeah.
Oh, you would need to do the entire thing.
Yeah.
Oh, because it's the cells themselves, not the duct.
Well, it's the branches of the small, like the little tiny branches. Within the liver. Yeah.
My goodness.
Oh, that's a fascinating.
Yeah.
That's a fascinating pathology.
Yeah. So really,
Person,
I know.
though. Wow.
So, moving on from that insane collation of diseases, like has pathology provided a lot of opportunities for leadership and research?
Yeah. So, looking at leadership, so we have our employer, who are New South Wales Health Pathology. So that's a statewide service.
Yeah.
So there are plenty of opportunities within that organisation for various roles. For about 10 years, I was supervisor of registrar training. And so I was then involved in the selection panels and aspects of training, which was great. Then the Royal College of Pathologists also has lots of roles within it as well. So I'm chair of the academic committee, which is looking at how to improve the profile of pathology for medical students, and also teaching and of pathology. And then I'm also, as you kindly introduced me, president of the IAP, which is International Academy of Pathology the Australian branch. So we hold an educational meeting every year as well. So they're all good opportunities to lead the way. And it's really up to you. I think some people are happy to come in, do their job and go home, which is, you know.
Which is fair enough.
Yeah, absolutely. Yeah, absolutely. You're not paid for a lot of this stuff.
Yeah.
So,
Money's money.
yeah, exactly. But I do find it gives, it does make the job more interesting when you're involved at a sort of higher level. I guess you have more influence, if you like. And then research, I think pathologists are in such a prime position because
you see so much.
We're guardians of the tissue. You know? So we're sort of, and we have that incredible depth of knowledge at the tissue level. So I've been involved as a pathologist on lots of different studies where they need someone, you know, with that knowledge, including the New England Journal study was so it was on track. So it's actually using oral nicotinamide to reduce skin cancers, which was a successful randomised phase 3 trial. Yeah, so that's changed practice around globally. So I was very fortunate to be involved in that, and they did a follow-up study in transplant patients as well. And then as part of that, I was grading all the basal cell carcinomas, which is a type of skin cancer, and that we wrote that up, and then it became part of the WHO classification. So that was, you know, excellent opportunity. So I'm involved with some other. They're doing a project using it's called ex vivo confocal microscopy. So it's actually
That's a lot of syllables.
Yeah. So it actually looks at the tumour. So they take the tumour out. Yeah. But before it's processed, the camera sort of takes multiple photos, like through the tissue.
Oh, it can scan through them.
Correct. And then reconstructs it. The tumour. So it's again not as good as paraffin. Yeah. But as a quick diagnosis.
You don't need to film and fix it, or you don't need to fix it.
Correct. So they're wanting to use it for, I don't know if you've heard of Mohs surgery.
No.
So it's for cancers in very cosmetically sensitive sites, such as the face. They take out the tumour and then they want to know the margins are clear, so they just shave tiny bits at a time.
Wow.
And
then you can scan through it and check if it's...
Also, normally they cut it.
Yeah.
Okay.
Yeah, they freeze it to use the frozen section, but they're hoping to use the confocal microscope instead to save a lot of time and actually keep the specimen intact as well, rather than having to slice through it. So that's, you know, fascinating as well. You know, there's a bit of I think sometimes there's a bit of a fear of artificial intelligence, but I say bring it on.
100%.
I think, you know, I was thinking about how much things have changed since I was a med student. We didn't have computers. I'm sounding really old here, aren't I? But, you know, there's no internet, there's no computers. We had to go to the library and use this microfiche thing. It was sort of like
what is it? A microfiche?
A microfiche.
So the journal titles and everything were, you had to look down at it. It was like a microscope, like these blue cards. I can't describe it very well. That had all the lists of the journals, and then you had to go and find the physical journal from the shelf.
Oh, so it's like a glossary.
Yes, yeah.
Like
but because of so much information, it was
very
tiny print, so you had to look at it under this.
Wait, that's insane. So they were like, we can't fit this many things onto one sheet of paper. Yeah. So let's just print it smaller and then magnify it.
Yeah, crazy stuff. Like, I can't even remember exactly how it worked now, but then you had to pull off the journals and photocopy. I mean, insane stuff. So it's what seems insane now, but it's, you know, so much easier now. So, you know, I embrace technology for the large part. I think it's made aspects of our job much easier. And that sharing of information is just amazing.
Yeah, this... Actually, firstly, God, that's a good line. Guardian of the tissue.
Yeah,
that's such a great line.
Yeah.
You should have a badge.
Yeah.
A sticker like that.
Guardian of the tissue.
Guardian of tissue.
Yeah.
And also, I think it's really interesting what you just brought up. This sounds a lot like I'm such a camera nerd now, but like it sounds like focus stacking, where you just take multiple multiple photos really, really fast, and then stack it all up, and then it becomes one clear photo. And in this case, it's a 3D image.
For the confocal microscopy. Correct. Yeah.
And it's really interesting to see how like tech evolves so we can get better at doing the things that we are supposed to be doing.
Correct.
It's like an adjunct. It unlocks more tools that we can use so we can be better doctors for our patients.
Exactly. A good analogy I heard was automatic pilot on aeroplanes.
Exactly, right?
Would you be happy to get on a plane where the pilot's using automatic pilot?
Yeah.
Would you be happy to get on if there was no pilot? Probably not.
It's, I think, probably even more like salient in our lives is automatic transmission. So like when you're driving.
Yeah.
When you had like before, obviously you had to like manually crank the lever into the right shaft.
Yeah.
And now it'll be very difficult for you to find a car that doesn't have automatic transmission, automatically shifting gears. Those decisions are made by a computer on your behalf.
Yeah.
And I think people would struggle now to go back to driving manual transmission cars.
I mean, GPS. Whew.
Oh, GPS.
For someone with no sense of direction.
Yeah, it'll be difficult. Yeah.
I mean, you're touching on artificial intelligence, and I think sometimes medical students have a bit of a fear that pathology and artificial intelligence, similar to radiology, they're not sure how that fits in the future. What do you think is exciting actually about pathology and artificial intelligence and how the workforce is looking to use it?
Yeah, I think something, I guess, that makes anatomical pathology a bit more difficult is we still have to make the glass slides first.
Yeah.
So radiology, you've already got the image.
Yeah.
We have to make the glass slides, and then they have to scan the glass slides to make the image.
It's like you still have to do the thing.
So it's quite labour intensive.
So you're actually introducing more time and need more labour at the moment to do it. Having said that, there are a small number of labs using digital pathology. And I think when it's up and running, I guess one of the things it will give is more flexibility, working from home, consults from regional
like telehealth,
areas.
But more pathology based.
Yeah, and that's actually, it's used very successfully now for teaching.
Okay.
The scanned images, very helpful. And I hope AI will take over some of the more menial aspects of our job. As an example, with a cancer, you have to screen lymph nodes for malignant cells. So you literally have to go up and down, and be fully focused. No pun intended. Going over the lymph nodes, and you might get 20, 30, So I think that's something I'd love a computer to do. And we have to count mitoses. So, some of those sort of basic tasks I think would be great if a computer did it. But I guess a sort of AI I use every day is actually voice recognition software for dictating reports. So it was a bit clunky when I started, but now the medical versions are amazing. I just talk normally.
It just dictates for you.
It populates the report, it gets to know my voice.
That's really fascinating.
So what do you think are some other misconceptions that people have about pathology?
I think that we're lonely weirdos who sit in a basement and don't talk to people. So, I think there's an idea that, if you have, poor social skills, pathology is a good job for you because you don't have to talk to people. But I think, you're constantly communicating with other doctors, with lab staff, with trainees. You obviously have to have a good grip of written language to, generate your reports, to teach, to interact at meetings. So I think, and I mean, some people think it's boring, but,
to each their own.
Well, to each their own.
Yeah.
I don't find it, there are other things I might find boring, but I find it very interesting. But I think really that we're maybe isolated or a bit remote or other, but, we're very much part of, integral part of the clinical team and of diagnosis. I think probably what I've heard more of is people wishing that they'd heard of pathology.
Ah,
As you know,
yeah, that's really interesting.
I've had quite a few specialists say if I'd known it existed,
yeah.
I might have,
Just jumped on it,
might have done it. So I think it's, really important as med students to be aware of all the, some people go into med school with a very fixed idea of what they want to do. But
she's like, I need this exact
I'm
field.
going to be a plastic surgeon.
Yeah.
But most or many people, I think, take a bit of time, which I think is probably a healthier, a good thing to do to, explore the different options.
Yeah, 100%.
But I think, one of our biggest barriers is people just not realising what a great job it is.
Yeah. And I think also there's not a lot of spread in terms of like, you don't see a lot of things until you go and actually be a part of the team.
Correct. Yeah.
And you don't see the actual aspects of it.
Yeah.
And along that, what are the benefits of a career in pathology?
Yeah, so I guess we've touched on some of them already, but I guess just really diverse and interesting range of work opportunities for teaching, research, good work-life balance. I mean, I don't think there's any medical job that's easy or strictly 9 to 5, but I think we certainly have a bit more control
It's
over
closer.
hours. And I've worked part-time a lot of my career with family, and it's been great. And even working part-time, I've still had full access to all the opportunities and seen and done as many interesting things as many of my my colleagues who work
Doesn't
full-time.
feel like you're missing out on too much by going full-time.
Correct, yeah.
Do you ever miss clinical medicine at all, or do you find that pathology has really given you, I guess, the full breadth of medical exposure that some people just, want to see?
Honestly, no. Not really. And I think possibly I think you have so much camaraderie within the laboratory. And obviously, it's great seeing patients. I think something else we really enjoy in the ward is actually working in that team environment. And you have that. And, through the multidisciplinary meetings, you learn a lot about, your patients as well. So, it's obviously not for everyone, but it's not an aspect I particularly miss.
So what tips would you give to a medical student who is interested in a career in pathology? Like CV, experiences, could somebody as a medical student try to do if they were very, very interested in pathology?
Yes, I think trying to get as much exposure as you can. So using your elective terms, for example, to try and get a placement in pathology, visiting laboratories, and not forgetting that you can also do that during your intern and resident year as well. If you can with your elective term, or I think you do, is it individual learning projects? Or
yes, we have a research.
Do something that's pathology based. And I guess this is broadly applicable to whatever specialty you go into, but going beyond the bare minimum is always, you can assume anyone who's finished medical school has done the requirements for a degree, but I guess standing out from the field if you can through doing this research project, taking on leadership roles. So, this podcast thing you're doing is great. If you have a pathology society, taking on roles in that, good to do the BPS, and really showing an interest in the field, taking the time so you're doing the right thing for you to speak to pathologists and trainee pathologists, because 5 years is a long time. Even if you think you love being a pathologist, you also have to enjoy the training.
And on top of that, after you finish training, you become a pathologist, and that's
correct.
That's
correct.
for as long as you choose.
Yeah. So basically, getting as much exposure as you can. I think, as I said, some people make up their mind very early. Some people don't make up their mind to their internal resident year, And that's fine. I mean, the same things would apply. But yeah, if you can, do, I guess, extra things on. I know you've got a busy degree, but probably have more time than you realise, particularly when you start working. But, to take on any additional opportunities you can to give yourself a good CV. There are opportunities to do honours or projects or anything like that. And the Royal College of Pathologists is on again this year a summer school for students interested in pathology. So the applications we haven't actually advertised yet, but if you look on the website, the applications are open. It's
now you know.
We've got a few have applied already. We also have scholarships for students to do pathology placements, and there's the BPS exam, which we touched on as well, which is a good thing to do while you're a med student as well.
Because it's cheaper.
Shows interest. And it's cheaper. It's cheaper.
And touching on the summer school, it was a great experience last year when I attended. And so for any listeners, I would highly encourage you to apply because it was a fantastic opportunity and definitely broadened my perspectives of what a career in pathology actually can offer and the different disciplines and hearing from different pathologists. It was really helpful. So I think it's well worth applying if you are interested in pathology.
That's great feedback. Thank you. And it will be in Sydney again this year, which is very...
Woohoo!
Yeah, very, very convenient. We'll be... I think the plan is to rotate it thereafter. But,
in Sydney, no excuses.
Do you have any final words of encouragement for any of our listeners about pathology and about how that relates to medicine and a career in the future?
And not specifically. I think we've covered it really well, but all the best to you and all the listeners for your studies. Big decisions to be made, but I think most people find something that's right for them. That is a fantastic thing about medicine. I mean, it's
quite broad, yeah.
It's a sort of glorified science degree, really. So there are so many things you can do afterwards. So having, I guess, an open and curious mind and take up opportunities as they come.
Well, thank you so much, Professor McKenzie, for coming on today. It's been a pleasure to chat to you about your work and about all the opportunities that pathology has. And thank you so much.
Pleasure. All the best.
Lovely.